think we're ready to get started here. My name is Jody Alwyn, and I'm the Director of Medical Education for Respicardia. We are very excited to have all of you with us today to learn from Dr. Javaheri and Dr. Khayat on current perspectives on how and why to treat central sleep apnea. Before I pass it off to Dr. Javaheri, I would like to go over a few Zoom logistics. I'm sure most, if not all of you, are familiar with Zoom by now, but please use the Q&A button, usually found at the bottom of your screen, and we will to ask a question. However, there are roughly over 200 of you on this call at this point, so we will do our best to address your questions as we can. I would like to introduce our speakers. Dr. Shahrokh Javaheri is a sleep physician from Bethesda North Hospital, professor of medicine at the University of Cincinnati, and an adjunct professor of medicine at Ohio State Medical School in Columbus. And Dr. Rami Khayat is a professor of departments of medicine and psychiatry and human behavior, and director of pulmonary and critical care fellowship program and medical director of the UCI Sleep Disorder Center in Orange County. Dr. Javaheri, it looks like you are ready. I passed the mouse over to you, so you should be ready to go.
Well, thank you so much, Jody, and I also welcome all the participants. And it's important that I do indicate that I have consulted agreement with Respicardia, but all the information we're going to present to you are based on scientific research. Let's go to the next slide. All right, well, my task is really why should we treat central sleep apnea? This is a patient in our laboratory with heart failure and reduced ejection fraction. I just want to show you an example of a research project of a patient that has a balloon in the esophagus here. And you can see down here. Can you see my arrow, by the way?
Yes, we can.
Okay, so as you can see, there are negative pressures. That's when inspiration occurs, of course. And then the balloon in the esophagus shows no activity, which means with the other flat lines, there's a central sleep apnea. And then there's gradually increasing negative pressure. You can all see the arousal occurs at the peak of hyperventilation. You cannot see the desaturation, but of course with the central apnea, there is a desaturation and a rise in PCO2, which is reversed with a resumption of breathing. Again, in contrast to OSA, arousal occurs at the peak of hyperventilation. It is commonly stated that the changes in intrathoracic pressure are not that much in patients with central sleep apnea. Well, it depends on what patient you're talking about. If the patient has heart failure, and as you know, in heart failure, there is congestion of the chest wall as well as the lungs. And depending on the amount of congestion, the lungs and chest wall are stiff. And therefore, with the hyperventilation, there will be large negative changes in intrathoracic pressure affecting cardiovascular system. With obstructive sleep apnea, the negative changes in pressure are here, but of course in central sleep apnea, it is further down, just like the arousal, which occurs here. And with the arousal, again, we have reversal autonomic system with increased sympathetic activity and decreased parasympathetic activity. So the qualitatively speaking, the changes in intrathoracic pressure and oxygenation are there, but less than those that are found in obstructive sleep apnea. Let's go to the next slide, please. And what's going on here? Oh, yeah, thank you. So here is the example, really a beautiful example of these regular irregularities in breathing. So gradually increased ventilation, decreasing ventilation, central apneas. Again, the pattern repeats. Characteristically, the central apneas are of the same duration. The amount of hyperventilation is also very regular. So this is really a beautiful regular irregularities in breathing that you can see, which is really an unstable respiratory system in heart failure. Just to point out, the patient has atrial fibrillation, which is a major risk factor for CSA in patients with heart failure and reduced ejection fraction. Could you go to next slide? Looks like I don't see the slide changes. Jody, could you go next slide, please? Okay, now let me just go over a little bit of why we think CSA should be treated in patients with heart failure. And the title, as you can see, it reads, Central Sleep Apnea Augments the Hyperadrenergic State of the Heart Failure. Remember, heart failure is already a hyperadrenergic state, therefore the use of the beta blockers. In the next few slides, I'm going to show you a few things, and again, this is quite expanded in the Journal American College of Cardiology a few years ago. So central sleep apnea is associated with the muscle sympathetic nerve activity, is associated with overnight urinary catecholamines, plasma catecholamines in the morning, and I'll show you several RCTs that show that in fact when you treat central sleep apnea by itself, it decreases the sympathetic activity. Let's go over these few things quickly. This is from Dr. Andreas, a cardiologist in Germany, just to let you see this. Here is muscle sympathetic nerve activity. The importance of the muscle sympathetic nerve activity, MSNA, is that this is from the peroneal nerve, and it reflects really the output from the brain in terms of its sympathetic nerve activity. So it's a direct output of the central nervous system, the vascular bed of the lower extremities, in this case, peroneal nerve. You can see with the central apnea, beautifully, you can see that the sympathetic activity goes up here. And next one, please, is Dr. Summers' work, I believe. Yeah, and here again, here is a patient with Hunter Cheyne-Stokes breathing. You can see the central apnea here, and during the normal breathing down here, there is a rise in sympathetic activity. They are quantitated down here per beats. And so these two slides that I have shown you show that specifically with each central apnea, the sympathetic activity goes up with each central apnea. Interestingly, this is a work from Canada that I wanted to share with you to emphasize the point. Look, there are two columns here, two separate groups of patients. This group has an AHI of 39. This group has an AHI of 42 per hour of sleep. Minimum SAT 80 in this case, 83 in the second group. Arousal indexes are relatively similar. Awake heart rate relatively similar. Awake systolic blood pressure, awake diastolic blood pressure. If you look at the awake MSNA, you can see they are very similar. And you can't tell which one is OSA, which one is CSA. The point is that both CSA and ASA increase sympathetic activity, and the amount relatively similar. Well, let me just go over the fact that if you treat central sleep apnea with different modalities of therapy, you will see a reduction in sympathetic nerve activity, so to speak. So here is a group of heart failure patients, baseline CSA, AHI is 48. This is the overnight urinary catecholamine corrected for creatinine. This is the morning plasmanorrhapy. You can see after a month of CPAP, you only attenuated the sleep apnea. There's still a lot left, yet there is a significant decrease in the urinary catecholamine as well as plasma catecholamine. I think one slide was, in this study, also from Canada, this is a group of heart failure patients with similar ejection fraction. This group has essentially no central sleep apnea, this group central sleep apnea. You can see the differences between the two groups in terms of the urinary catecholamine as well as the morning. Look, this is the group without central sleep apnea. And if you go to the next slide, when you treat the group of patients with central sleep apnea, the level of catecholamine overactivity really goes back as if they did not have central sleep apnea, like the previous group I showed you, which is this group. All right, let's go forward here. That was with CPAP. And we're going to go with, this was the CPAP, right. Well, this is a very interesting study by Pepper et al., which was published in the Blue Journal quite some years ago. The interesting part of this is a randomized, double-blind, placebo-controlled study. So this is a group of heart failure with CSA on ASV. This is subtherapeutic ASV. If you look at the catecholamine in the urine, you can see the group that was on ASV versus the group that was on subtherapeutic ASV. There was a significant reduction in the catecholamine. You can see the reduction is in the negative here, whereas the group on subtherapeutic, there was actually a little bit increase in the overnight catecholamine. Next one, please. So this was really a double-blind, essentially placebo-controlled study. I think there's one slide on oxygen that was missing. Let's go back here. Yep, here it is. So this is another double-blind randomized control trial. In this case, this group of patients with HFrEF and CSA, severe central sleep apnea, you can see. They either receive a concentrator which provides oxygen or a concentrator that provides room air at the same amount of flow rate. You can see that AHI goes down to 25 with oxygen, so not completely eliminated, and remains relatively unchanged with room air. And if you look at the central apneas, 13 to about 4, the room air is about 18, a minimum saturation improves with oxygen. And again, when you look at the urinary catecholamine, almost 50% reduction compared to either baseline or placebo. So that was oxygen, that was CPAP, and that was ASV. So, of course, you all know why this is so important, because it is well known that increased sympathetic activity carries a poor prognosis in heart failure patients, hence the use of beta blockers. Now, I want to show you a couple of slides from my colleague, Rami, when he was close to me in Ohio, in Columbus. I don't know what I did to him that he left, but he would probably elaborate on that. So he looked at a large number of patients with no sleep apnea, central sleep apnea, and OSA. Here I have summarized the data from the CSA patients. These are patients with severe left ventricular ejection fraction, 22%. You can see large number of patients here. And when they were discharged from the hospital, 1 month readmission was 150% higher than those without CSA, the 6 months the same. And look how many variables he accounted for. So after accounting for all these variables, CSA was independently associated with increased readmission at 1 month and 6 months. Excellent study. Let's go to next slide. Well, this is our own study at the VA, which I would like to emphasize a couple of points. This is the survival. This is the follow-up. This is a long, long follow-up. You can see that individuals with heart failure, HFrEF, and no central sleep apnea versus those with central sleep apnea, there was a significant difference in survival. In fact, the hazard ratio is about 2. And in really multivariate analysis, out of the 24 variables, which included systolic blood pressure, diastolic, ejection fraction, and so on and so forth, 3 important variables turn out to be the case, which are very interesting. One was central sleep apnea, the low diastolic blood pressure, and the low right ventricular ejection fraction. So the higher the AHI, the lower diastolic blood pressure, and the lower RVF were associated with increased mortality, independent of the other co-founders. Again, the hazard ratio is about 2. And this is, I think, also from Rami's study. Again, look, the survival, the follow-up is on the x-axis. And if you look at the survival, the interesting point is this. So this is the group without the sleep apnea, the group with central sleep apnea. You can see it is very similar hazard ratio of about 2, similar really to what we reported, which is interesting. But of course, this was in Columbus. I'm in Cincinnati. We were close. I don't know if that has anything to do with it or not, Rami. But let me show you a study transatlantic. Now, this is from Germany. The importance of this study are twofold. First, it is done by very expert cardiologists. That is a very important study. Important point number 2 is the number of patients involved, 962 patients. You can see that there are 3 lines, no significant sleep apnea, obstructive and central, and it appears that both obstructive and central sleep apnea were associated with increased mortality over many years. These patients, as I said, were followed by cardiologists who are well known. These are very well treated patients with heart failure and central sleep apnea, and again, clearly shows increased mortality associated with central sleep apnea. There were other factors that were associated, but central sleep apnea was one of those factors. So with everything said, let's go back, I think it jumped. With everything said, the question is why the SERVE heart failure failed. You're all familiar with the SERVE heart failure, the largest randomized control trial based on a multi-nation study. And as you can see over the 60 months follow-up, surprisingly, the control group had better survival than the ASV group. In fact, there was an absolute increase, 2.5% in cardiovascular mortality in the ASV arm. So the treated patients were unfortunately prematurely dying faster than the control group. And the question really is, why was that the case? Here is in the actual paper, the authors indicate ASV effectively treated sleep apnea, and that is correct based on the average values. You can see that AHI at baseline was 31, and the average decreased to about 6 and 7 over the follow-up period. But when you look at actually the supplement, which is what we did, you found something very interesting. If you look at the 3 months, 12 months, and go forward, there is really a large range in AHI, which suggests that there was a subgroup of patients that ASV was not quite effective with residual AHI, as also evidenced by residual desaturation. So at baseline, 51 minutes below 90%, but across the board throughout the study, we can see 18 to 25 minutes below 90%. Not only that, but please look at the range of desaturation. So there are individuals at 12 months that may spend 268 minutes below 90%. The same at 36 months, 291 minutes. So you could argue that not only the patients were not well treated in a subset, and there was significant desaturation left behind, which of course could have played a role in the mortality here. I don't know why this jumps. Okay, so I think this is where I was in the slide. So let me go to next slide, if it doesn't jump on me. So I wonder how many of you may have seen such a thing, because this is most probably what happened in the trial. I see this frequently. Actually, it would be unusual for me to look at an ASV study and do not see this phenomenon. This is a patient with HFrEF on ASV. You can see the thorax, abdomen, and the sum, flat lines, central apnea. The patient's on ASV. However, when you can look at this black line, what you see, these sharp dips, is that ASV is trying to open up the airway, and it is failing, because nothing is moved the chest and abdomen are flat, even though the device is trying very hard. In fact, if you can see down here, this is the inspiratory pressure support that is reaching max to 30. The EPAP has maxed. So the machine right now is functioning as a bi-level device at 30 inspiratory pressure, 15 expiratory pressure, and a backup rate that is incapable of opening the upper airway. The upper airway is closed, no matter what you do, until eventually the patient wakes up to breathe. There's an arousal here. So this is what we call a closed upper airway central apnea. It happens all the time if you look at your ASV device. It would be unusual if I don't see one. And let's make sure I didn't miss slide here. So you can see not only yeah, so actually what happened is, which I don't have much time to go into details, is really very, very interesting phenomenon that at one point there was excessive pressure affecting the heart, excessive ventilation when the airway opened up and causing probably hypocapnia and arousal. And in the long run, I believe the cumulative effect resulted in both myocardial and conduction system remodeling and eventually deaths, either daytime or nighttime. The other issue is really the amount of time these patients actually use the device. So you can see in the SERV heart failure, the average was about 3.2 to 3.9 hours, and almost 34% less than 2 hours, 52% more than 4 hours. So there was some group that used the device more than 4 hours, 40%. So what we have asked from the investigators of the SERV is the following question. There is a 40% of the patients who have used the device 5 hours or more. Show us the data on mortality of some of these patients that use the device, that ASV lowered AHI and improved oxygenation. We are interested in the survival of this subgroup. We appreciate it is going to be a subgroup analysis, but at least we should get some idea of this group of patients who use the device more than 5 hours and they were effectively treated. We need to know, compare that group of patients with some other patients in control that were matched for certain things, of course. Again, we appreciate this is a post hoc analysis. So let me also go over a couple of things with you and say that as the night progresses, things really change. I want to emphasize this part because the rest you know, like CSA is not uncommon in REM sleep, though OSA worsens, but some people may not know that data are accumulating that in non-REM sleep, as the night is progressing, OSA worsens, and so does the CSA worsens. So as the non-REM goes on in the later part of the night, close, in the morning hours, in the non-REM sleep, both OSA and CSA worsens for interesting physiology. And of course, if the patient changes position, both OSA and CSA worsen in supine position. So we need a device that really works out through the night, like the ASV or a CPAP, that the person wakes up in the middle of the night at 4 o'clock in the morning, takes it off and sleeps for 2 more hours, and things are going to worsen later on. That is not a good therapeutic efficacy. So this was a study we did, published about a year ago. This is all in non-REM sleep. And this is throughout the night. As the non-REM sleep goes on, you can see that CSA worsens in non-REM sleep as night goes on, and the same with OSA in non-REM sleep. And in association with that, arousals go up as well as the ODI go up. So Dr. Rami, myself and another friend, we really discuss in detail. This is a critical paper we discussed in detail how and why the served heart failure might have failed. Again, I pointed out few points, but there are many more points in the discussion on this paper, and I strongly urge you to take a look at that if you're interested. So that brings me to the final few slides. What are the options to treat central sleep apnea? And again, you can see for yourself. Just to mention that we do have Dr. Khayat, myself are involved in a long-term trial with oxygen, which is approved by National Institute of Health, which is ongoing. And we have done, of course, RCTs with both these drugs. Also with the Phrenic nerve stimulation, published previously. Dr. Khayat, I believe, will talk about that. Let me see. Yeah, so this is I think I'm going to stop here, Rami, and give it to you for further discussion.
Thank you very much, Shahrokh, and thank you for the organizers for this opportunity. It's always a great pleasure and honor to be with Shahrokh, actually, and with everyone on the call today. Thank you for everyone for making it. I always learn a lot from every presentation I've been with you, Shahrokh. So thank you. And you know, I hold you responsible for the mistakes I'm going to make now as I present, and responsible for answering all the difficult questions that are going to come up. I used to be at Ohio State, and I have recently moved to the University of California, Irvine, but I remain also associated with OSU and collaborate with Dr. Javaheri on several projects, actually. My discussion will be more into practical approaches and how we can actually translate the great information that Dr. Javaheri went over with us into our practice and decision making. I will start with a few things I'm going to highlight from Dr. Javaheri's note and discussion. One of them is the fact that, and actually these are his findings too, that central sleep apnea is present mainly in patients with heart disease. So, and this is kind of a two-way thing. On one hand, the severity of the heart disease will affect the severity of the central sleep apnea. But also, as we contemplate treatment approaches to central sleep apnea, we do have to keep in mind that all these patients are ones with underlying cardiovascular disease. A patient with central sleep apnea we diagnose in the sleep lab will have, you know, anywhere from 60 or 70% chance of having underlying heart failure with or without atrial fibrillation. There's also an effect of having stroke, and most of us do see cases of what we call idiopathic, but the actual etiology of this is really not clear. So the consideration here is that the underlying cardiovascular disease is critical for the pathogenesis of the central sleep apnea and for treatment decisions, such as the treatment must not be harmful to the underlying heart disease. Dr. Javaheri also showed these slides, and I refer the audience to an excellent review that Dr. Javaheri spearheaded recently in CHEST on a practical approach based on the pathophysiology of sleep apnea, albeit this slide is somewhat simplistic, but it summarizes some of the interventions based on the underlying pathophysiology. So we're all familiar with the concept of high loop gain, that is denoting the excessive ventilatory responsiveness in patients with central sleep apnea. One of the mechanisms that low flow oxygen impacts is the loop gain. Also these therapies, and again, you know, the audience is referred to Dr. Javaheri, who's done most of the work in these areas. These do target this particular mechanism. There has been some information that many of you are aware of too regarding the use of hypnotic agents, sleeping pills for central sleep apnea. And you know, there are limited data on positional therapy. Again, from practical standpoint, we can comfortably say that, you know, the results of these sort of like single mechanistic or single mechanism agents do not justify necessarily at this point using them in clinical practice. The studies were often smaller physiological studies, short duration of follow-up, and the side effect, particularly for the medications, that applies only to the medications, theophylline, acetazolamide, and the hypnotic agents, have not been necessarily evaluated in heart failure patients over a long period of time. Oxygen is probably one of the safest interventions here, and it is currently under investigation in the trial that Dr. Javaheri mentioned, the LOFT-HF, which we're both and many, hopefully even some people on the call are involved in that trial. We are trying to understand the long-term effect and benefit of low-flow oxygen in central sleep apnea in patients with reduced ejection fraction. So this remains at this point only covered through that randomized controlled trial. There are the most commonly used treatments so far are the ones that target several mechanisms. I think a question that comes up is, and again, we don't have time really to answer this, and I probably don't have a really good convincing answer. How does CPAP actually eliminate central sleep apnea, and how does phrenic nerve stimulation improve central sleep apnea? PAP has several mechanisms understood. For example, it stabilizes the upper airway, decreases the overshoot associated with the obstructive events. It may increase the CO2 reserve and stabilizes the breathing below apnea. It may decrease the interstitial pressures in the lungs and the stimulation of the J receptors and other mechanisms that are attributed to PAP in general, positive airway pressure. There is less known about the phrenic nerve stimulation, and often, for most therapies, the focus is on the efficacy, and this device has shown efficacy, but as far as how it does it remains under investigation. We presume that it does decrease the overshoot. It targets the respiratory motor output and entrains the ventilatory or the basal output from the respiratory control centers, and likely prevents post-arousal overshoot and responses to any other stimulants that produce hyperventilation during sleep. That being said, all this is speculation, and mechanistic studies are justified in this area as well. Again, a few recaps. We said that PAP can eliminate or can control central sleep apnea. However, the pivotal randomized controlled trial for CPAP was the CAN-PAP study published in 2006, and it showed that CPAP did not improve any of the primary or secondary outcomes in patients with heart failure with reduced ejection fraction and central sleep apnea. There was no change in mortality and or of any of the other secondary endpoints such as ejection fraction or functional outcomes. There was a post hoc analysis, and a lot has been written, including by Dr. Javaheri, regarding its applicability to practice. I would say safely that yes, in a subpopulation of patients with central sleep apnea and underlying heart failure, CPAP can improve the AHI, but whether you believe that this will improve other outcomes, it has not been shown it's been shown only in a post hoc analysis. But you do, and we all see this in our labs, that we can sometimes eliminate or decrease the AHI in a patient who has predominantly central sleep apnea with CPAP. The fact that CPAP can do this only in a portion of the patients prompted the interest, and I think I'm kind of trigger happy here too a little bit with the mouse, but the interest in devices like the ASV. And again, in the interest of time, I will not discuss the mechanism of action, but I think it's beyond question that we all have seen the magic response that ASV produces in patients with central sleep apnea. It does indeed improve the AHI. Dr. Javaheri and I were involved in this acute study in which we looked at patients with underlying predominant central sleep apnea and compared the effects of CPAP, auto SV with or ASV with fixed EPAP and with auto EPAP, and we saw how the auto or BiPAP auto SV was very effective in eliminating central sleep apnea. Again, the SERVE-HF followed, and I think it again, Dr. Javaheri covered the findings on our concerns with it, but it remains that we have to heed the warnings, and this is how it is in practice right now. It is prohibited to use, however you look at it, ASV in patients with heart failure and reduced ejection fraction. We just cannot do it in this population. It is possible in some investigators' mind to generalize to any device that increases the intrathoracic pressure, because the SERVE-HF, one of the least kind of told issues is when you generate this data about a study, about a device saying that it's negative without showing the mechanism of harm. Actually, it left a lot of questions to be answered in people's mind. In clinicians, for example, well, what ASV, what type of pressure settings, is CPAP the same, is BiPAP the same, is BiPAP with backup rate doing the same thing? So all that being said, we know for sure that ASV is out of the question for this population. I want to spend some time discussing the, actually I want to just go over this first, is one of the most established mechanisms of harm for positive airway pressure is these findings from the 90s by Dr. Bradley, Dr. Becker, and others who looked at administering positive airway pressure to patients and measured the cardiac output, non-invasively or invasively. And in this particular series, there were 9 patients. They had OSA. They were awake when this is done, and they were exposed to gradually increasing PAP, and the cardiac output decreased in somewhat of a dose fashion. Similarly, in a group of patients, and again, acute study, awake patients with heart failure, and again, the increasing PAP pressure resulted in decreased cardiac output. Later, Dr. Bradley looked at this in relation to the filling pressures and found that those with high filling pressures tolerated the higher pressure better than those with lower filling pressures. Regardless, we think that this may be a factor that positive airway pressure may be harmful in these patients, but again, these cannot be generalized beyond the ASV. At this point. I want to discuss now for a few minutes the phrenic nerve stimulation. And again, I do not have conflict to disclose with the company at this point regarding this device, although I was involved in the earlier studies with it. But of course, with no financial interest to disclose. This study is actually the device itself. This is what this slide will I'll provide an overview. It's an implantable device done by an electrophysiologist and placed generally on the right side, not to compete with the implantable devices of the typical heart failure patient. There is a sensing lead and a stimulating lead, and the procedure is just like any other pacemaker implant done in the electrophysiology lab. It's a same-day procedure. The pericardial phrenic vein is cannulated with the stimulation lead. There is also an alternative approach to go on the right side if this was difficult, but this is done, for the most of the patients is cannulated successfully. For those of you who are familiar with pacemakers, it does resemble that. Obviously, it is pacing the diaphragm, not pacing the heart, and it does thankfully stay away, and it does not have really any negative interaction with implantable cardiac devices. This study was evaluated in a randomized controlled trial. But in this slide, I'll be able to show you here just kind of an on and off from one patient over one night. This raw data here, this is the oxygen, abdominal belt, thoracic belt, airflow. And in this portion of the slide, the phrenic nerve stimulation was off. On this portion, the therapy was turned on. And it's very clear how the periodic breathing pattern is completely eliminated. There's a stable breathing pattern and stabilization of the oxygen saturation as well. So very effective for purely central sleep apnea. The randomized control trial was published in 2000. I thought it was actually 15. Now it's been a while. And was a multi-site trial that enrolled, I'll show you this in a subsequent slide, 151 patients. But the inclusion criteria was central sleep apnea. And I will make a note here that in this study, we attempted to capture predominantly central sleep apnea to stay clear from those who have 50-50 split and significant obstructive component. The primary endpoint was the effect or the proportion of patients who had more than 50% reduction in AHI. And then hierarchical secondary endpoints looking at central apnea index, apnea-hypopnea index, arousal index, and these other important functional endpoints and sleep quality endpoints. Safety obviously was very important and was at the rank of a primary endpoint because it's an implantable device and it's somewhat new to the to our sleep field to be implanting. Although this came after Inspire, it was very important to demonstrate safety, especially in this type of population. So the 151 patients were all implanted. 73 were randomized to the treatment and 78 to control. So everyone had the device in them, and the therapy was turned on in the first month in the treatment arm, and the control arm remained off for 6 months. At 6 months, the endpoints were collected, but it's very important to note that everyone was followed to 12 months and 24 months, and the controls had their therapy turned on at 6 months. So they were, if you will, crossed into, of course, without intention to treat it, but they were crossed into the treatment arm, and they provided significant observation for additional observations on safety and effectiveness of the treatment. So the outcomes of the trial, again, were the proportion of patients who had more than 50% reduction in AHI. And there was 51% of patients having this outcome versus 11% in the control arm. Every single endpoint, primary or secondary, was met in this trial. For example, there was a reduction of 25 plus minus 18 of the central apnea index compared to really no reduction in the control. The AHI decreased by 23 events per hour compared to by 1 in the control arm, and so on. A lot of people were interested, including me and Dr. Javaheri at that point. Arousal index, did that change? Actually, it improved in the treatment arm. It's not that the stimulation was waking patients up. And, there was no reduction in REM sleep, which also was another concern for people. Are we making people sleep less? And that's why we're having, an improvement. That was not the case. People slept better and their AHI improved. And there was significant, safety profile for the device, which I will not cover now, but there were really no adverse effects or dropouts. This graph, if you visualize this here, each bar is a patient, and it just shows the size of improvement. So this is percent improvement in AHI at 6 months and at 12 months. And very healthy range with a majority of patients, well above 50% reduction in AHI. I will make a note here that, again, compared to treatment devices that the patient will wear only for half of the night, if you're getting 50% reduction in AHI over 100% of the night, then that's at least equivalent to 100% reduction in AHI in a device you wear only 50% of the night. So that has to be taken into account. But again, the majority of patients experience more than 50% reduction. A few notes about the practicalities of this implant. It gets programmed. People ask us sometimes. We program it with the what we call gating for the patient's sleep time. So if you say the patient goes to bed from 11 to 6, then the device will turn on during that period of time. If the patient wants to shift that window, it can be reprogrammed to accommodate that. It doesn't just turn on if the patient was going to be up watching TV or doing something out of usual. There are several conditions required for the device to come on. It has to occur within that window of sleep. The patient has to be in a reclining position and even past a certain degree of reclining, and they have to be still for some time. If they wake up to go to the bathroom, the device will stop, or if they do significant shifting in their sleep, the device will temporarily halt the stimulation and then will turn on after a, again, reprogrammable period of time, but often it's 10 minutes. So it is not very intrusive, and there are various settings that can be programmed. I will spend a few minutes here to discuss a practical approach. Dr. Javaheri and I proposed this recently. I think that showed up on my computer here, sorry. Again, I would say we're now in a little bit of, in a period of uncertainty. There are really no large randomized controlled trials governing the practice of central sleep apnea. So a lot of decision-making has to depend on clinical judgment and individualization of therapy, and sometimes kind of, expert opinion. I will say an approach, a possible approach. Again, this is published recently. If a patient with heart failure and reduced ejection fraction is diagnosed with central sleep apnea and therapy is optimized, and let's say the central sleep apnea was eliminated, then that's fine. We don't really see this in our practice much, because when they come to us, they're often optimized. There are some missing arrows here, but if someone was optimized and they ended up with predominantly obstructive sleep apnea, then they can follow the path of OSA and get titrated in the lab with the appropriate PAP therapy for their OSA. Now, if they have persistent central sleep apnea, you have these options really. I mean, they can be enrolled in a randomized controlled trial such as LOFT, which we would be happy to do that, because we're really interested in learning about the effect of oxygen in patients with heart failure, reduced ejection fraction, and central sleep apnea. It is possible to use CPAP with a caveat that it does not improve long-term mortality or change significant heart failure-related outcomes, but it can eliminate central sleep apnea in a portion of the patients who receive CPAP. So there is required significant follow-up to make sure the patient is responding and using the device. And unfortunately, we're learning more and more that acceptance, tolerance, and long-term usage is limited to. So the clinician has to make some decision. Is the patient responding to it? Are they partially responding? Can I add something? Can I, for example, have them elevate the head of the bed, add some other therapies, or perhaps add oxygen? These are all, if you will, off-label, and they would require quite a bit of discussion with the patient and clinical judgment. At that point, if they were non-responsive, they can be considered for, phrenic nerve stimulation. Of course, phrenic nerve stimulation is an FDA-approved, clinically indicated treatment for central sleep apnea. So it can be a first-line therapy equal to any other intervention when you encounter a patient with predominantly central sleep apnea. It is technically the only intervention right now that has FDA approval. Again, the long-term outcomes in heart failure patients, there is safety, there are positive effects, there are good trends in it in papers we've published, but we cannot say that it will make the patient live longer, but obviously there is no therapy right now that does that. So that bar really is not required for any intervention. We know, however, that we do need to treat the central sleep apnea. So if we put patient on a phrenic nerve stimulator, we have to follow them, obviously, and that's part of the algorithm for that. The one thing obviously is missing here is ASV cannot be used in this population. How about if the patient has central sleep apnea, but they do not have reduced ejection fraction? Say they have heart failure or preserved ejection fraction, or no heart failure, or heart failure, with that equivalent ejection fraction or AFib or something like that. Right now, some people generalize from the data with ASV, and I don't really fault anyone, but there is no evidence that you cannot use ASV in that population, but a lot of practitioners are not prescribing ASV if there's any label of heart failure. So leaving it at that, you can optimize the medical therapy and reassess the patient. If it is persistent central sleep apnea and the patient has no heart failure, you can put them in the lab and titrate them. And again, if it's a positive airway pressure device, you really have to follow up carefully to make sure there's tolerance, there's acceptance, and there's responsiveness. And if there is that, then that's great. If it isn't, then one can consider phrenic nerve stimulation. You can easily also consider phrenic nerve stimulation as a first-line therapy in these patients because it's FDA approved for central sleep apnea, regardless of underlying heart failure. And again, the follow-up will be per, we typically follow these patients, after we stabilize and determine responsiveness to the phrenic nerve stimulator, we follow them every 6 months. And I'm not going to be able to show you the download here, but there is significant information similar to even what you get from the download of your airway, your positive airway pressure device like CPAP or ASV that would allow you to make adjustments. So I will stop here so we can allow, and I'm seeing some questions, coming in. So thank you, everyone, and I will turn it to our moderator maybe to help us navigate the questions.
Yes, I will. I will allow Catherine. It looks like you raised your hand, and you should be able to speak. You need to, if you're on a phone, you might need to *6 yourself. I'm unable. Well, yeah, they're raising their hands and I am unable, I've allowed them to speak, but I'm unable to unmute them. There's some questions.
Do you want us to start?
Well, let's go through the questions.
Them?
Yeah, you can start the questions that you're seeing. That there's a lot of questions coming through. You guys seeing them okay, or would you like me to read them? The first question is, why do heart failure patients have central sleep apnea more than the general population?
Dr. Javaheri, I can.
You can go ahead, Rami. No problem.
I mean, it's it's multifactorial. There are conditions in heart failure that produce this. For example, decreased cardiac output, decreased cerebrovascular responsiveness, pulmonary vascular congestion. So it is definitely more than genetic predisposition. It is something that's related to the heart failure. One of the most commonly implicated pathways is that when the heart failure patient assumes the supine position, there is increased venous return in the pulmonary vasculature, which causes some pressure on certain stretch receptors located in the lungs called the J receptors, which are linked to our respiratory control centers producing some hyperventilation. So the patient then starts breathing faster, and then they can drop their carbon dioxide to below the apnea threshold and develop apneas. There is somewhat of a circulatory delay. There's a little bit of disconnect due to that between the peripheral chemoreceptors and the central chemoreceptors. So it is numerous factors related to the heart failure. One of the ones that are less highlighted often in the discussion is the effect of heart failure on blunted responsiveness in the cerebrovascular vessels, which results in dampening the responsiveness of the central chemoreceptors. I'll stop here because this can be a topic for a very long period of time. Dr. Javaheri, anything else?
No, that's fine. Let's see.
Yes, so there is the common result from CPAP and ASV and phrenic nerve stimulation is all decreasing AHI, but one has no effect on mortality and another increase. The question is, how do we know if phrenic stimulation results the same? By the other hand, what makes this device more successful in controlling disease outcome and mortality?
Is that the question from Dr. Jafari, right? Or that you're reading?
Yes, it is, exactly.
Yes. Okay. Okay. Yeah. You know, that's a good question. I mean, I think, you know, CPAP, for example, the long-term trial, Behruz didn't really show that it was killing patients, but it did show. So, you know, the concern necessarily isn't always there that, so CPAP is not over-ventilating patients. The phrenic nerve stimulation does not provide excessive ventilation to patients. The mechanism why the ASV caused the harm was presumed to be related to the either increased pressure or the increased ventilation, both of which don't exist in the phrenic nerve stimulator intervention. And again, CPAP, even with it being a positive airway pressure device, it didn't really increase mortality. It just didn't decrease it. So I feel the concern based on the phrenic nerve stimulation in being harmful in heart failure patient is not justified. There has been now a few publications and long-term follow-up. Safety is there, but whether it improves survival, you know, no one can say that, that's for sure.
Right, yeah, okay. What about patients with diaphragm paralysis or elevation?
You know, a good question. To my knowledge, it has not been used or studied or FDA approved for that. And remember, you know, it will kind of depend on where the site of injury is, whether the intervention will be responsive to that. I have heard from some of my colleagues in Respicardia that there was consideration or some information, but I don't know if anyone of them is on the call to help answer this, but I know there is no FDA indication for this.
Yes, this is Jody. That is correct. That it wasn't studied. It wasn't a patient population, and also the device is only able to stim for it's not meant for 24-hour stimulation. It is only programmable for a maximum about 12 hours, and it just so. But that is not our patient population nor our indication. Are you familiar with Dr. Thomas' work at Beth Israel in Boston utilizing PAP with dead space ventilation for more complex CSA patients? And if so, any opinions?
Yeah, we're certainly familiar with his work. And Rami, actually, you used dead space when you were in Wisconsin.
Yes.
Why don't you go ahead and respond to the question?
Yeah, you know, I think it's, you know, it's sound pathophysiologically. You know, Dr. Scatrud, the late Dr. Scatrud and Dempsey and others, we looked at dead space in patients with central sleep apnea, and it did really stabilize the breathing pattern. Dr. Bradley has done work in this area and others, and I'm familiar with people adding it to positive airway, you know, for that. I think it's possible. You know, the concern in dead space ventilation is whether you risk increasing CO2 in patients with heart failure, and what mechanism or what way you have to actually monitor this every night, because they will vary from night to night, and whether you know, on one night they will retain more CO2 or will have less CO2. So there sometimes could be a little bit of a moving target. That's the only comment I will have. But in our study, you know, which was one night study, patients were very responsive. So I can see it being promising. I've heard several people taking it on, but I haven't seen convincing data yet. Dr. Javaheri, anything to this? I'm sure you follow
There
this
was
more.
one study that also it increased the arousal index. So I think care should be taken regarding that as well, because we're trying to really decrease the arousal index. I think one important point regarding some of the questions, in my opinion, is that in the randomized control trial of the cpap, the arousal index did not decrease significantly, even in the subset of patients in whom CSA was suppressed by CPAP. So it is very important because of the role of the arousals in autonomic nervous system. Whereas with the phrenic nerve stimulation, the arousal index significantly decreased. And we're hoping that perhaps with non-mask therapy, either phrenic nerve or oxygen, perhaps the same thing, that the arousal index would go down as it did with the phrenic nerve stimulation. And I think that's an important issue, because I think perhaps the reduction in arousal index in the RCT of the phrenic nerve stimulation accounted for improved quality of life, which was not observed in the cpap trial nor in the ASV trial. So there is a difference between interventions that are non-mass therapy versus perhaps interventions that are otherwise, regarding how the patients feel, the overall arousal index, and even perhaps both in terms of phrenic nerve as well as oxygen. Perhaps it is the fact that the overnight adherence will going to be hopefully more improved, better than otherwise with CPAP and ASV. And as you know, both in the cpap trial as well as ASV trial, under research conditions, the adherence to CPAP was about 3.5 hours. And as we pointed out, both of us, as night progresses, central sleep apnea gets worse in non-REM sleep in particular, and therefore the full adherence is also critical, even though the effectiveness may not be that great. But the fact that the patient is using it all night long, particularly the latter half of the night, that's an important issue. So the overall AHI goes down, the overall arousal index go down. So I think overall this may prove to be in balance, very effective therapy, so to speak, oxygen as well. And we'll see about that in the left heart failure.
I'm going to make some comments that hopefully can address some of the questions. So the remedē is indicated for central sleep apnea regardless of underlying heart failure. So the trial was for central sleep apnea only, regardless of underlying heart failure, even though many of the patients had heart failure. So I saw some questions on that. It was not studied for patients with neuromuscular disease or, traumatic phrenic nerve injury or something like that, for obvious reason, because you don't know the site of injury and the responsiveness. It is not indicated for daytime stimulation like the surgically implanted phrenic nerve stimulator. And I'm seeing some of my friends here. I think Sai had a question about ASV and central sleep apnea. I mean, I don't know, I'm gonna put myself out there and I say I do prescribe ASV for patients with central sleep apnea who do not have reduced ejection fraction. I don't know about others here. I have not, stopped using it for central sleep apnea in general, but I'm sure, I would be open to, other people's, approaches too, because it's complicated.
This is, I mean, we're running past the hour, but as long as there are still quite a few folks online, and if you both are okay with answering some more questions, I don't think we'll get through all of them, because again, there's what was well over 200 folks, and there's a lot of questions coming in. But if you guys are okay, we can answer a few more. Sure. This is, please discuss using carbon dioxide as a therapy for CSA.
Yeah, I was just typing. I'll let Dr. Javaheri, you just discuss the issue on this if you want to.
Right. So again, there are several studies that you can increase the PCO2 a little bit. Dead space was one of them. Actual administration of carbon dioxide is another one. There are two potential methods, what we call a static administration of CO2 versus dynamic administration of CO2. The static meaning that you use a small amount of CO2 throughout the ventilatory cycles. And because PCO2 is such an important determinant of central sleep apnea during non-REM sleep, i.e. when a small reduction in PCO2 below the apneic threshold causes the central apnea. If you elevate it a little bit with administration of CO2, of course, that is why it is so effective. At the same, by the way, with the static, with the dynamic CO2, which I think is very interesting field, there's a little bit research going on where you administer the CO2 only in part of the respiratory, the breathing cycle. And I think that would be a good one if we could demonstrate efficacy and also that the arousal index doesn't go up. But the mechanism is very important, that a small increase in the PCO2, maintaining the prevailing PCO2 above the apneic threshold will prevent development of the apneas, so to speak. I don't know if that answers the question or not.
How about, my patients don't have desaturation below 88% for 5 minutes. Do you give them low flow oxygen too?
Well, oxygen is not approved by Medicare for either central sleep apnea or obstructive sleep apnea unless you are on CPAP, appropriate amount of CPAP or whatever ASV, if that's what you're using, and you still are desaturating independent of the presence of sleep apnea. So at least in Cincinnati, DME companies do not provide oxygen for just central sleep apnea or obstructive sleep apnea under the circumstances that there is persistent sleep apnea.
Okay. Dr. Khayat, do you see any others that you think you could answer? Or here's what was the subset analysis in SERVE HF trial where the time below 90% and AHI range have effect on mortality? Kind of.
That's the big question.
Yeah.
That's the one that we do not have that. That's what we've been asking, to provide that information in a subset analysis. The group that used the device, that it was effective in decreasing AHI to a low threshold of less than 15, less than 10, and there was not significant desaturation. That outcome of that subset in a sub-analysis, in a propensity analysis is very important. We still don't have the data on those for whatever reason. I am not sure.
You know, I will say that I wonder if the questioner was asking about the slide from Dr. Oldenburg's data too. But so the data Dr. Javaheri presented on the relationship between hypoxia and heart failure and mortality was from a different group, was a very large observational study from Germany. But SERVE HF, they failed to show that data there actually. So it's, you know, but the slide that was shown was from another study.
Okay. Mm-hmm.
All right. Well, I think we kind of, there's still so many questions and I feel bad, but I think we're past the hour. So, and for those of you asking, I had a lot of questions if this was be recorded, and it will be recorded and will be sent out via either through your rep or the emails. But again, we have that list. So we are going to record it, and we will be sending this out to you if you're interested. Thank you, Dr. Javaheri and Dr. Khayat, so very much for your time and your fantastic presentations. I always learn so much by listening to you both. And I thank you all for joining. We had a good group of folks on. So thank you everyone for joining. And thanks again, Khayat and Dr. Javaheri for presenting.
Thank you everyone. And thank you for sticking with us too. So I appreciate
Absolutely.
the opportunity. Thank you.
Thank you all as well. Thank you, Rami.
Thanks, Shahrokh. Good seeing you.
Vice versa. Yeah. Bye-bye.
Bye-bye.